welcome everybody to this AO Trauma North America Journal Club, where we're going to be discussing elderly femoral neck fractures. Now, I'm your host for the evening, Roman Natoli. I'm joined by several moderators. We have Dr. Jang, Dr. Harkin, and Dr. Goodnow. And we have our esteemed faculty, Dr. Okike, Dr. Kerr, and Dr. Shemich. These are our disclosures, none of which are relevant to the presentation or content this evening. Further disclosures from AO. The AO staff involved in this educational activity has no financial relationship to disclose. They do acknowledge funding for the educational activities, which is received from Synthes. And all rights for these educational resources and assets are owned by AO North America, and all its contributors are for educational purposes only. AO North America is an independent nonprofit surgical specialty society dedicated to improving care of patients with musculoskeletal injuries. It does not endorse or promote the use of any product, service of commercial entities, and the equipment used in this course is for demonstration and teaching purposes only, with the intent to enhance our learning experience. So here's our agenda for the evening. Currently, I'm welcoming you. When I'm done, we're going to watch video 1, where Dr. Harkin interviews Dr. Okike on not all garden 1 and 2 femoral neck fractures should be fixed. Video 2 is Dr. Goodnow interviewing Dr. Shemich on total hip arthroplasty versus hemi-arthroplasty for hip fracture, which is known as the health trial. And finally, we'll see Dr. Jang interview Dr. Kerr on the influence of door type of femoral fixation and outcomes following total hip arthroplasty for acute femoral neck fractures. And then we're going to have an open discussion. And probably between 9:10 and 9:15, we'll end up wrapping up. The learning objectives for the Journal Club series are to review classic and current journal articles to understand why a particular study was conducted, to be able to explain how the literature advances or historically changes orthopedic practice, identify best practices, in this case for elderly femoral neck fractures based on quality scientific evidence, and then participate in live discussions about practice-defining concepts and principles. More specifically to this particular journal club, upon completion, you should be able to state the main finding of the FAITH trial, identify salient risk factors for failure of elderly femoral neck fracture fixation, discuss the risks and benefits of hemi-arthroplasty versus total hip arthroplasty for displaced elderly femoral neck fractures, and then describe the role of cementing the femoral component in elderly femoral neck fractures undergoing arthroplasty. I've chosen, or collectively, we have chosen these articles because as orthopedic surgeons, when we have an elderly femoral neck fracture, we're faced with surgical dilemmas, beginning with should we fix it or replace it? Once we've made that choice, how do we fix it and how do we replace it to get the best outcomes for our patients? So we're going to turn it over now to the video 1.
Well, thank you again so much for joining us to talk about your influential paper. I was hoping to just kind of start things off by getting an idea from you what prompted this secondary analysis of the FAITH trial data to investigate this really important topic.
Yeah, it was actually at OTA when I saw the study initially presented, and I thought a few things. Number one, outstanding study, very hard to do randomized trials in orthopedics, but also, there were many patients with displaced fractures in that trial, and I thought to myself, well, we kind of already know that those should probably be treated with arthroplasty, but they were treated with various forms of fixation in the trial. And that got me thinking, okay, well, what about the non-displaced fractures that were in that trial? There was still a relatively high rate of reoperation in that study, around 13%, and other studies as well. And it got me thinking, okay, so should we not be fixing any of these undisplaced fractures as well? or is there perhaps a subset that we shouldn't be fixing? And if we could identify those, it would perhaps help us lower that rate of reoperation to the level that we see in arthroplasty or displaced femoral neck fractures, only a couple percent, versus the 10, 15% or more that we see in undisplaced or non-displaced fractures, which some would argue are a less severe injury.
Yeah, certainly. I think those are some great points, and it's great to see that insight and kind of how everything developed. Can you talk a little about some of your primary outcome measures? I think you already mentioned a few.
Yeah, so we set the study up as a secondary analysis of the FAITH trial. And I should take this opportunity to thank not only my co-authors, but all of the surgeons who participated in the FAITH trial. As was mentioned, really a Herculean effort to produce data that's really been helpful to our field. So what we did is we took the non-displaced portion of the study sample, and our primary outcome measure was reoperation within the 2 years that these patients were followed for the FAITH trial. And the primary predictor that we looked at was the degree of posterior tilt. So displacement seen on the shoot-through lateral radiograph. The Garden classification is what we typically use to distinguish between femoral neck fractures in the elderly, and that's typically done primarily on the AP view, with 1s and 2s typically getting fixation, 3s and 4s typically getting arthroplasty. And so we thought that the lateral view should be considered as well. Some of the other predictors that we included of note were age and gender.
Yeah, and with what you found, I guess, with those kind of primary outcome measures, what do you think are 2 or 3 of the most important points that our readers and our audience here should kind of take away from the paper, and how this might change their practice?
So the most notable finding was that in patients who had posterior tilt of 20 degrees or greater, they had a much higher rate of reoperation within that 2-year window, about twice as high, 22% versus around 11% for patients who did not have posterior tilt to that degree. And that's the most notable finding. It's something that I have carried over into my practice, whereas previously, I think like many people, I would fix nearly all Garden 1s and 2s, whereas now I closely scrutinize that shoot-through lateral. If the patient doesn't have an adequate shoot-through lateral, I'll send them back to get one. I really do think it's important to essentially weed out fractures that are doomed to fail, and allows me to do arthroplasty on them primarily. 2 other factors that we found to be associated with reoperation. The first one was age. So age over 80 was significantly associated with reoperation. And then female gender was close. It was, the p-value was 0.06, so there was a trend toward that. So in my practice now, I have a much higher threshold to do fixation and a much lower threshold to do arthroplasty. So really for any patient where their age is starting to get above 80, especially if they're female, and definitely if there's any posterior tilt, I'll now do hemiarthroplasty, as opposed to previously those are patients I may have been fixing.
Yeah, I think the paper definitely is influential in kind of steering us towards that for that patient population, and seeing the kind of additive effect of age over 80 with females with the posterior tilt too is impressive. If you were to redo the study or the analysis today, is there anything that you think that you would do differently?
In doing the study, we were limited in the number of confounders that we could include, even though it was a very large study, large randomized trial, and we ended up having over 500 patients in the non-displaced portion. You are restricted by the number of events so that your model isn't overfitted. So if we were able to do the study over again with more patients, I would have tried to include more comorbidities as potential confounders as well as potential predictors. But I think really the next study that needs to be done in this field is basically asking the question of should we be replacing all non-displaced femoral neck fractures, or is there some sort of algorithm fix those that don't have posterior tilt, aren't over 80, perhaps aren't female, and replace all the others? Is there some sort of algorithm whereby we can get our reoperation rate down to the level that we've come to expect for hemiarthroplasty? Like I said, all Garden 1s and 2s taken together, reoperation rate maybe 15%. Hemis maybe a couple percent, 2, 3, 4%.
Right.
So if by eliminating those kind of high risk fractures, can we predict who they are, and can we get our reoperation rate down into that 2, 3, 4% range? Or can we not predict all the people who are doomed to fail, and even in taking the high risk patients off the table for fixation, we still have a higher reoperation rate? Should we not even be trying to figure it out anymore and just replace all of these?
Yeah, I think that'll be very interesting. And is that is the next step, hopefully, to try and create that algorithm from the data set?
Yeah, that's my hope. There are randomized trials that have come out since comparing fixation to arthroplasty in the Garden 1s and 2s, and they do find a lower rate of reoperation in the hemiarthroplasty group. I think the question remains, if we can separate out those high risk fractures, maybe there isn't a difference. So, obviously doing randomized trials is difficult in orthopedics, but that's definitely my pipe dream.
Yeah, of course. Well, again, congratulations. An excellent paper, and, very influential for our practice. And we really appreciate that. Thank you for your time tonight. And, we're looking forward to the live event and some great discussion here in a couple of weeks.
Sounds good. Thank you.
All right, Dr. Emil Shamish, thanks for joining me from University of Western Ontario. Today we're going to be talking about your study with the health investigators. Thanks for being here.
Pleasure to be here.
Yeah. So the background for the study is that arthroplasty is a pretty conventional treatment for displaced femoral neck fractures in geriatric individuals. And the question is whether to perform a total hip replacement or a hemiarthroplasty. And the idea is that total hip arthroplasty may give better functional outcomes in the long term and have lower rates of secondary procedures. Presumably hemiarthroplasties in the wrong patient would require conversion to a total hip arthroplasty in the future. The downside is that total hip replacements are thought to have slightly higher risk of postoperative instability. And so against that backdrop, with no high level evidence one way or the other, your team designed this international multi-center randomized controlled trial to compare hemiarthroplasty to total hip arthroplasty in geriatric individuals. So this is a study of 1,495 individuals from 2009 to 2017. The patients were greater than 50 years of age. They had to have a displaced femoral neck fracture, be an independent community ambulator, and this would be an isolated low energy, able to be treated within 3 days by an expert surgeon who does greater than 50 procedures or has done greater than 50 of either of these procedures in the past. Primary outcomes were the primary endpoint was unplanned reoperation within 24 months. The secondary outcomes were death, hip-related complications, and functional outcomes. And just to highlight the main findings were that there was no difference in the primary outcome of unplanned reoperation within the first 24 months. So 7.9 or 8% of patients that got a total hip went on to have an unplanned reoperation, and 8.3% of hemiarthroplasties had a secondary procedure. So no significant difference. In terms of sub-analysis, there was a higher rate of instability in the total hip crowd, with 4.7% of them experiencing dislocation, which was double the 2% of the hemiarthroplasty group. And then the functional outcome scores that you used were the WOMAC functional scores, which were slightly improved in the total hip arthroplasty group, but underneath the minimally clinically important difference. So statistically significant, but not clinically significant. And so, Dr. Šimić, just wanted to know what was the driving force, the motivation for the study for you and your team?
Well, I think the key here is that it's a really common problem. There's a real significant burden of disease with hip fractures. And back then, the best surgical treatment really was uncertain. And what we had wanted to do was look at the best method of internal fixation, actually, against the best method of arthroplasty. And that led to the development of both the FAITH and HEALTH trials. So the FAITH trial being an internal fixation trial, and the health trial being the arthroplasty trial. So we wanted to determine what was the best method of arthroplasty in the health trial. So either a hemiarthroplasty or a total hip replacement.
Great. So one of the chief limitations that's been cited in this study has been the relatively scant follow-up. So 2-year follow-up in this study showing no difference in functional outcomes. But I think the advocates of total hip replacement would say that if you followed the hemiarthroplasties further out, you would certainly see an increase in chondrolysis and conversion to a total hip in the future. Now, without further follow-up from this study, we do have a recent study from JBJS in 2020, which looked out at 5 years in terms of reoperation rate and functional outcome, total hip versus hemiarthroplasty, and again showed no difference. So no difference at 2 years and 5 years. And so my next question, I think, for you is, at what point, if any, at what time point, if any, do you think we'll finally start to see a functional outcome difference in this group and a difference in reoperation rate?
Well, I think, again, it's probably going to come down to longer term follow-up. So I think the data is pretty conclusive that up to about 5 years, there's not a meaningful improvement in the total hip arthroplasty group, but the follow-up is only to 5 years, and potentially out, to 10 and 15 years, we may see a difference. I think the other thing too is, how it is that we actually categorize the, the patients. We did an exploratory sub-study looking at functional outcomes at 2 years between a hemi and the total, where we looked at the fittest patients in the health trial, but fitness was defined as young patients, ASA 1 or 2, independent walkers or at home, and those patients we didn't find an advantage. But it may be that in patients that are higher functioning, so that are participating in sports and recreational activities, those patients may actually notice a more meaningful difference. So I think it's about longer term follow-up, and then looking at higher functioning patients who are expected to lead an active life beyond 5 years to determine whether, in fact, those patients are the ones that are going to benefit from a total hip replacement.
Great, thanks. I think we'll expound on that a little bit further in one of my final questions for you. I think this is such an interesting data set that you and your team have had a couple of studies be offshoots of this. And at one of the recent OTA annual meetings, you presented a sub-analysis of the hemiarthroplasty, the patients that were treated with hemiarthroplasty. And specifically, I think you found that a decent number of patients were getting bipolar hemiarthroplasty and a decent number of patients were getting unipolar arthroplasty. And some surgeons that advocate for bipolar hemiarthroplasty cite less of a risk of acetabular erosion, maybe greater hip range of motion. Your sub-analysis was elegant. It was a propensity matched sub-analysis and showed no benefit in terms of functional outcome, no benefit in terms of decreased reoperation rate for the bipolar hemiarthroplasty. Do you have any advice you can give us in terms of indication for bipolar hemi for femoral neck fracture?
Again, I think, one of the big limitations of this sub-study was the, short-term follow-up. So at 2 years, there was absolutely no advantage. But one real significant uncertainty is, what happens to high-functioning patients that are expected to live an active life beyond 5 years post-fracture, similar to the total hip arthroplasty patient population. And, the question is that more active, high-functioning patient that's going to live longer going to benefit from a bipolar in either function or reduced revision rate? And certainly if you look at some of the registry data, particularly in young patients under the age of 70, you see improved survival of a bipolar at more than 5 years compared to a unipolar arthroplasty.
Okay, so potentially in the longer, those expected to have some longer survivorship. Great.
That's it.
One other sub-analysis that you performed was a cost-effectiveness study recently published. Can you tell us the conclusion of that study comparing the cost effectiveness of total hip replacement versus hemiarthroplasty?
Yeah, I think again, it comes down to that younger patient cohort. So we found that total hip arthroplasty may indeed be cost effective in younger patients. We broke the cohort down into 4 quartiles, and we found that the youngest quartile, those who were younger than the age of 73, that total hip arthroplasty may indeed be cost effective. And if you look at that patient population, they experience more meaningful improvements in quality of life and they recover quicker. So there's less associated costs because of shorter hospital stay, and there are fewer post-operative complications. So when you put that together, it looks like in that younger patient population that a total hip actually may be cost effective.
Okay, very interesting. So I think we're arriving at a kind of a take-home message from this study, as well as this subsequent analyses that you and your team have performed. But who, if anyone, do you think may benefit from a total hip compared to a hemiarthroplasty after a displaced femoral neck fracture, given everything we've seen so far?
I think in a nutshell, it's a very specific patient population. So I think it's really a high-functioning, high-performing, active individual that's under the age of 70 that has a life expectancy beyond about 5 years. And I think, if you look at the data and where we're at in 2023, I think that's the patient population that I would be focused on.
Okay. Well, Dr. Šemić, I really appreciate you taking the time to visit with us and go through all of your work, and I'm looking forward to participating in the panel next week with you. Thanks very much.
Yeah, thank you. It's been great.
Welcome, and thank you for joining us, Mike here. How are you today?
Good. Thanks for having me, Johan.
All right. Well, we before we go on in detail to discuss about your discussion of your paper, where did you guys get the idea of this study?
Yeah, it's a great question. So I was actually inspired to start the study during residency when I saw a patient who had a femoral neck fracture get treated with a press-fit total hip, and then they had a post-operative femur fracture about a week or so later. And as both of us know, the Academy guidelines, recommend cemented femoral stems in arthroplasty based off of the hemiarthroplasty literature. And some of those guidelines also support total hips over hemis in select patients. So what I really wanted to do with this study was to investigate whether femoral fixation and the femoral bone stock, which we classified by door type, affected the fracture rate for these patients undergoing total hip arthroplasty. And part of the impetus for that too is there's also been some recent registry findings in favor of cemented stems in total hips, in particular in femoral neck fractures. But our study was really the first non-registry study comparing outcomes of cemented versus cementless total hips for these low energy femoral neck fractures. And we tried to hone in on some of the granular detail in that study.
And what did you guys actually find?
Yeah, so we found that cementless stems had a higher all-cause aseptic femoral revision rate. And this is specifically for periprosthetic fractures, whereas cemented stems actually had 0 fractures in our cohort. Most of these fractures occurred within the first 3 months after surgery. About 20% of them, or 1 in 5, occurred intraoperatively. When we did the log regression and we took into account all these confounders like patient and surgical factors, we still found that cementless stems and door C bone were big risk factors for fracturing. We really didn't find any other differences in terms of dislocation rates, deep infections, or even mortality. And we also looked at temporal trends, which is kind of interesting, across these 3 institutions that were involved. And we found a decreasing trend in cemented stem utilization. And that's despite a pretty stable proportion of door C patients over time. So it's pretty interesting what we were able to do with this multi-center study and really hone in on the details in this.
What do you think that the most important thing to take away from this your study?
I think the most relevant finding for surgeons is that the cemented stems had 0 fractures compared to press-fit stems. Personally, what was most interesting to me was that each successive door type had a higher fracture rate with cementless implants, and that even door A had a decent number of fractures. And so it was 2.3% in door A, 3.7% in door B, and it was a very high and alarming rate of 16% in door C. To me, that's a high rate in all groups, even in the door A. I mean, in door A, that's about 1 in 40 patients that gets a fracture. And in door B, that's about 1 in 25. And in door C, that's about 1 in 6 patients fractured, which obviously is very alarming for most of us to think about.
What were some challenges for this study that you had?
I think the biggest challenge was, we tried doing the study as a single institution initially. We just didn't have the numbers. And so, the challenge was getting enough patients to be adequately powered to detect differences. And so we ended up doing this by engaging collaborating institutions and doing a multi-center study across 3 large trauma and arthroplasty centers. And we had about 96% power for determining differences in fracture rate. Some of the challenges were we weren't powered to detect other differences like implant characteristics, even though we looked at that as well. But I would say that was probably the biggest challenge, was trying to do this as without using a registry to really get this granular detail. You need a lot of centers to be involved.
Would you do anything different?
Yeah, it's a good question. I think that goes back to kind of this last thing you asked me is, if it was possible, I would have liked to have more centers involved over a shorter time period. I think our time period was pretty broad, and that was to just encompass all of those patients. And really, cementless stems have evolved in terms of their design and geometry in recent years. particularly collared stems, which a lot of surgeons have been using instead of cemented stems for patients at risk. I think the jury's still out whether these collared stems are protective in dorsal bone, but that's something that I think, with more centers involved, that we can probably study in the future, especially as these stems are relatively new. So they haven't been on the market too long. But I think as we get more long-term data, that's kind of the next step.
I think there is a difference for this total hip arthroplasties done for the femoral neck fracture compared to hemi.
That's a fantastic question. There really is no real difference technically for the femoral side when you're doing this, obviously. The literature is focused on hemiarthroplasty, and those patients, as we know, tend to be sicker. We often think of, the ideal hemi candidate as somebody, the demented patient with multiple comorbidities who falls and has a low energy fracture and requires a hemi. I think the difference lies in the thinking that, and this is kind of the current dogma, that patients who get total hips tend to be healthier candidates and may do better with cementless stems. However, I think we're trying to challenge that. So hopefully this study demonstrates that regardless of whether a patient is a candidate for a total or a hemi, that femoral neck fractures may do better with a cemented stem in terms of reducing the fracture risk.
In your opinion, your patient on the study for cemented group for total hip arthroplasty for femoral neck fracture, were they sicker?
Yeah, you're right. The cemented patients in our study were generally just slightly poorer health, I would say, but they were not incredibly sick patients. Like you said, the ASA wasn't different between the cohorts. Compared to press fit or cementless patients, they were about 7 years older, slightly lower BMI, etc. But really, they were not incredibly sick, and that's kind of hence why they were candidates for a total hip replacement. Their general health was not poor to the point where they were hemi candidates. Decent ambulatory status beforehand, good mental status, things like that. So I think it was a fair comparison of patients who were deemed healthy enough to get a total hip, but we still found that cemented stems were protective in that group. And I think part of that too is, yeah, they had a slightly higher rate of being diagnosed with osteoporosis prior to their admission. But I think the fact that they had a femoral neck fracture also kind of self-declares that diagnosis as well in all of those patients.
Why do you think that door type did not show any association with a fracture in the elective total hip, but it shows association in a femoral neck fracture?
Yeah, that's a great question. There's a couple studies that looked at elective total hips, and they didn't find that door type was associated with femoral neck fractures. And we likely, they didn't see it associated with periprosthetic fractures. And we likely saw the effect here because all of our patients had a femoral neck fracture. Again, in my eyes, they self-declared that they have a poor state of bone health. And so we were more likely to see that effect here. And, in my eyes, again, all of these patients should have a diagnosis of osteopenia or osteoporosis, whether it was formally diagnosed or not. The other thing is, these are all trauma patients that come in. So unlike the elective total hip, they're not optimized. They're not, 2 months beforehand where, our elective hips undergo quite a bit of optimization to get surgery, including quitting smoking, alcohol use, optimizing their nutritional status and their labs. These are trauma patients, and really you can't do any of that beforehand with these patients. And so I think that lends to a few differences between looking at an elective total hip versus a patient that comes in with a femoral neck fracture.
Thank you. Based on the AJRR, the significant number of the femoral neck fracture cases are still going non-cemented. Why do you think that some choose to or prefer to do non-cemented hip arthroplasty for femoral neck fractures?
Yeah, again, I think this lies in the traditional thinking that these patients have less comorbidities and they should have healthier bone. And we're really trying to challenge that dogma in this paper. And I think, part of the other thing is there's recent modern cementless stems with collars that may be protective of fractures. And there's some studies out there that has shown that, but the literature is very scarce on this topic. And I'm guessing that's why some people are still using cementless stems for both of those reasons. And colleagues that I know that choose to use a cementless stem over a cemented stem tend to choose a collared stem, or they tend to choose a design that they think would be preventative these days. And, our study obviously encompassed a huge time period. So some of those stems were not existent 10, 15 years ago, but those do exist now. And I think we need to study that some more. But I do think that we should not lose the art of cementing because, because of this study and several other studies that show it is truly protective of fractures. And maybe we'll get more data on collared stems, but until then, I think, we should not lose that art of cementing, that cementing technique, and teaching residents and trainees how to do that.
There's a 10-fold increase in pulmonary complication in your paper. Do you think that this can be a deal breaker for some?
Yeah, that's another great question. So we found 5 total occurrences of a perioperative PE, and 4 of them occurred in the cemented stems. 1 occurred in a cementless case. So it's 10-fold, but that's 2% versus 0.2%. And it's also unclear whether these were fat emboli or whether they were thrombotic emboli. And, this being a retrospective study, we really couldn't parse that out. The good thing is it wasn't a cause of mortality for any patient. But that's, one of the weaknesses of our study was this broad time period. And so I think we're better at preventing and catching PE today than we did 10 or 15 years ago. But back to your question, I don't think it's a deal breaker per se, but it's something that definitely needs to be communicated to our anesthesia colleagues, intra-op and pre-op, to prevent PE in the first place, and to just have a low threshold post-operatively to rule that out as well.
And I just have one last question. What next after this study?
Yeah, I think the big response I got from some of my colleagues about this study is, they've been challenged to consider using more cemented stems in their practice. One of the things that's preventing them from using cemented stems is, they've been comfortable using these modern collared cementless stems for these patients, and they believe that the rates are similar anecdotally in terms of fracture rate. So I think really the next step is to study the use of these modern cementless collared stems in these patients and compare that to cemented stems and see if that really does reduce the fracture rate and possibly prevent the PE rate as well. So that's what I think we can go from here.
Awesome. Well, Dr. Kier, I appreciate your time. Always a pleasure talking to you and picking your brain about this complex issues. I appreciate your time. Thank you.
All right, I'm going to load back up the slide deck for a second, potentially. There we go. So first of all, thank you to the moderators and to our faculty. I think those videos, the interviews were excellent, very informative, getting at the heart of a lot of the questions that we ask and face when it comes to dealing with elderly femoral neck fractures. Now, one of the studies that we did not do a formal interview about, but came up multiple times, is what's called the FAITH trial. So I wanted to make sure that that was at least acknowledged, and we can talk about it a little bit if we want to. But that was for fracture fixation and the operative management of elderly femoral neck fractures, international, multi-center, randomized again. These were patients aged 50 years or older with a low energy hip fracture. Primary outcome was hip reoperation within 24 months after the initial surgery for any of these reasons. And there were 557 sliding hip screws and 551 cancella screw constructs. And straight from the abstract, but if you dig into it, I think, it really, the data really supports what this conclusion is. In terms of reoperation rates, the sliding hip screws showed no advantage, but some groups in the cohort subset analyses showed that smokers and those with displaced base of femoral neck fractures might do better with a sliding hip screw than with cancella screws. The other slide that I wanted to go over, but also was brought up several times, was the American Academy of Orthopaedic Surgeon guidelines regarding cementing in elderly femoral neck fractures. It's a strong recommendation with a strong level of evidence, 2 or more high quality studies. And I think we heard, another decent quality study tonight, that patients undergoing arthroplasty for femoral neck fractures, the use of cemented femoral stems is recommended. And yet I think all of us probably know colleagues and or patients, and maybe we've even done it ourselves, where we've chosen not to do that, even despite some pretty overwhelming evidence to the contrary. So to review the things we were supposed to learn, and then we're going to have the discussion, you should hopefully be able to state the main finding of the FAITH trial. Dr. Okike went over some salient risk factors for failure of elderly femoral neck fracture fixation. Based on the health trial, there appears to be a very similar risk-benefit profile for hemiarthroplasty versus total hip arthroplasty, ultimately with no difference between the 2 groups, especially functional outcomes. And then the role of cementing femoral component in elderly femoral neck fractures. I mean, I do have a bias here. I cement them. So, I mean, I think that the role is pretty clear, for both hemis and totals, that it should be cemented. And so hopefully this helps answer some of the surgical dilemmas. The first question that I want to ask, and it's actually the first question that came up in the question and answer from our participants, was, and I want to read it directly, is there a role for CT scan? And this was when the first video was going on. So Dr. Okike, is there a concern for obtaining multiple lateral x-rays and a potential risk for displacing the fracture? Are you doing a cross table lateral or a frog leg lateral? And then after you start discussing that, the other thing that comes to mind for me for CT scans is, every once in a while, you can't really tell if it's displaced, or when you're trying to measure 20 degrees on x-ray, is it better to measure 20 degrees on a CT scan, et cetera? So basically, what's your thoughts on CT scans for femoral neck fractures and ones that you may or may not be able to tell if they're displaced?
Yeah, thanks for that question. I do cross table or shoot through laterals. There are some who argue that, having a hip fracture patient do frog leg laterals is mean. I tend not to do CTs. But, this study was looking at 20 degrees of posterior tilt. And I think since we did this study, I've gotten even more kind of conservative in that really, if there is any degree of posterior tilt that I can see on x-ray, I will start tending towards hemiarthroplasty these days. I just think hemiarthroplasty is such a good operation, works well. If you're choosing to fix a non-displaced femoral neck fracture, you got to be pretty certain that patient's not going to fail. And I just think the onus is on us to not have these patients reoperated because they just do so poorly.
Other faculty members, Dr. Kerr, Dr. Shemich, your thoughts on the role of a CT scan?
I personally don't typically get a CT scan. I might get a CT scan if I'm unsure of the diagnosis, but once I have the diagnosis, then I pretty much leave it at the plain films, and I typically tend to get a shoot through lateral. And again, just in terms of decision making, I've got a pretty low threshold for going to an arthroplasty. So internal fixation is going to be done in a younger patient with pretty much no angulation, and it's pretty uncommon these days for me to be doing internal fixation in a fragility fracture. It's more and more arthroplasty.
Yeah, similar. Yeah, no CT usually. Being at a large academic university, though, a lot of our patients that come to the ED happen to get a CT, but I wouldn't necessarily need one.
Yeah, I agree. A lot of the patients we see also have CT scans for whatever reason, not ordered by orthopedics. I think it's interesting because I hadn't really thought about this a lot before your paper, Dr. Okike, but when you start to look at the CT scans or even the cross, laterals, it's amazing that we thought that the screws that, if you're using 3 screws, were ever really getting into the head, because once you start to get, quite a bit of angulation, there's not a path that's really good for those screws to get from the lateral cortex of the femur, up into the femoral head. So if someone's on the line and they haven't actually looked at that before, it's, pretty eye-opening. The first time I started to think about it, I was like, what the heck was I doing? All right, this question, let's ask Dr. Kerr first. So if you don't know, Dr. Kerr is not a trauma trained surgeon, though he does trauma operations. He's an arthroplasty trained surgeon. What approach should we be using for arthroplasty? We didn't really talk about all of that in all the discussion of arthroplasty. So, or should we do direct anterior, anterior lateral, posterior? I'm interested in the faculty's thoughts on the approach.
Yeah, it's a great question. I don't think there's great studies that have looked at approach and outcomes for femoral neck fractures. Certainly there's quite a bit of studies that look at direct anterior versus posterior approach in elective total hips. And I will say that largely there is no difference between them in terms of outcomes, in terms of recovery, in terms of dislocation rates. There are some recent studies and large registry studies that have shown maybe a slightly lower dislocation rate with direct anterior approach, but it's not impressive and it's not consistent across studies. In terms of recovery, there's a lot of marketing out there that discuss direct anterior patients recovering sooner. The best studies out there show that they recover maybe 2 weeks sooner, and then there's no difference at 3 months, 6 months, 1 year. So I don't know the answer to that for femoral neck fractures. I do both direct anterior or posterior approach for those. Kind of depends, I think, on their BMI. So if they have a high BMI, I likely will go posterior. It's easier and they have a lower risk of a surgical site infection. If they're skinnier, I'll tend to do it anterior.
I think if you look at the evidence, I think what the literature would say potentially is that the patient who has the direct, like a Harding approach, doesn't do as well with an arthroplasty. And you might say, well, that's the traditional approach to avoid instability. But in actual fact, these patients who are sort of teetering on the edge in terms of function, I think when their abductors are disrupted to do the approach, they actually don't do as well functionally. And there's actually registry data that says that. So I think if you're going to fix one of these, ideally in terms of functional outcome, you're probably better off either doing a direct anterior or posterior. I think the posterior approach classically has been associated with more hip instability. But I think, if you're using a larger femoral head, you're doing a careful capsular reconstruction, make sure you put the components in really good position and consider the use of dual mobility. I think that instability difference disappears. And I find that for me, it's the sort of workhorse approach. So I pretty much will do the posterior approach routinely in this patient population.
Connor, are you also a posterior approach or something else?
I think that's an interesting question. I think some of the things that Dr. Shemich mentioned are kind of more recent things, dual mobility, for example. Certainly the historical data shows that there is a higher rate of reoperation with hemis that are done via posterior approach. I think many of us rarely see a dislocation from a hemi, but in the literature, it does happen, and it's a higher rate with posterior approach. So me personally, for patients where I am kind of concerned about their kind of function, I'm typically doing a total hip, and I do that through a direct anterior approach. But for the old kind of low function, demented patients where I'm doing a hemi, I'll typically do an anterolateral approach because dislocation is what I'm concerned about, as opposed to their being able to hike 4 miles.
So we've talked about the role of cementing for elderly femoral neck fractures. I guess one of the questions I was thinking of as this was going along, is there any patient who should not be cemented for an elderly femoral neck fracture? Classic arguments, the quote, pulmonary cripple. I don't know. So just throwing that out there, is there somebody that that we think with kind of overwhelming evidence for cement that should actually not be cemented, and you should do a press fit for whatever your choice is, hemi or total arthroplasty?
I'll jump in first on that one. Oh, sorry. Go ahead, Dr. Shemich.
Well, I was just going to say, I mean, I think in general, these patients should be treated with a cemented implant. And it may be in that sort of gray area of the patient who's 50 to 60, maybe has a higher energy mechanism, has a door type A femur, good quality bone. In that patient population, I would potentially consider using an uncemented implant. But it's almost universal that I'm going to use cement in a patient that's got a fragility fracture, femoral neck fracture. Like there's almost no indication otherwise for me to use an uncemented implant.
Yeah, I'm a pretty strong proponent of cement. I think the concerns that many surgeons have about cement implantation syndrome, which occasionally is seen in higher rates in certain studies, that's primarily due to confounding by indication. The patients getting cement are a little bit older, are a little bit sicker, and more prone to these things. The studies that have been done that are actually randomized, or we did one with propensity scores, you tend to see that go away. I do think you can get your risk of cement implantation syndrome very, very low. But that being said, there are a small number of patients where I won't do cement. And yeah, these are patients where, their EF is 10%, they're on HOMO2, they're on high dose pressors throughout the case. Patients like that, I will forego cement, but it's a pretty rare occasion.
Yeah, I agree. And not to beat a dead horse, but yeah, high energy mechanisms, I agree, are a different beast, like what Dr. Shemich was saying. I think, all the patients in our study were all acute low energy fractures. And so they were likely osteoporotic, but these high energy femoral neck fractures are a completely different beast. And if they're healthy enough and high functioning, I would consider cementless stems for them in terms of possible higher longevity. But I think you should still have a very low threshold to cement regardless, especially if they're older. And you should always look at their bone quality and do things case by case.
Dr. Shemich, there was a specific question for you about whether you're using dual mobility on all your femoral neck fractures that are undergoing a total hip.
In general, I would now, because I think that the patient population that is best served by a total hip is a young, high performance, well-functioning patient population. So it's typically, someone under the age of 70, who's very active, maybe plays tennis, that kind of thing. And that patient population, being that active, I think is at increased risk of instability. They're a patient population that does not have arthritis, so they don't have the, the contractures that you would normally see in an OA patient population. So they tend to be at fairly high risk of instability. And we saw that in the health trial where the instability rate was twice in the total hip population. So I feel that dual mobility is a good option. It's easy to do, and I think really helps with that issue of instability. So I routinely would use it in the patient getting a total hip.
Anyone else using dual mobility, not just for the faculty, but Dr. Harkin, Dr. Jang, Dr. Goodnow?
Yeah, I do use your dual mobility on all femoral neck fracture patients that I treat total hip. I think the hip stability is one of the thing, and I do use an anterolateral approach. So I do rely on dual mobility at some point, but I think that the literature evidence is not there to support that dual mobility actually do support lower rate of complications or dislocation rates or anything like that.
I mean, I think one of the things that requires study in this area is the whole issue of the surgical approach. And I think in the past, we've been, very, very focused on, hip instability, trying to avoid posterior approaches. And, the historical approach has been to use the, anterolateral approach or Harding approach. It's been solely focused on reducing challenges with hip instability. And as I said earlier, I mean, one of the challenges is that there's more to the patient's recovery than just avoiding a dislocation. It's also about function. And I think sometimes in this patient population where function can sometimes be a challenge, doing something iatrogenic to the hip abductor mechanism, I think does lead to challenges in terms of functional outcome. So that is my perception, but I don't have any sort of proof to back it up. And I think this whole notion of approach is something I think that requires study, and I think would be something that would be an excellent topic for a randomized controlled trial.
Is there something you're not telling us, Dr. Šemić?
That's it.
I'd love to poll the panel, kind of activity level and dementia and comorbidities aside. What is the age above which you're pretty much almost always doing hemi, and the age below which you're usually doing total? Dr. Šemić mentioned 70. I think for me, it's probably closer to 80, but I'd be curious to see what others think. Again, comorbidities and other things being more important.
Yeah, I'll start with that one, and it might not help very much because I really go by the functional status. And so I've done total hips on a few patients that are, high 70s, low 80s. I've never found somebody like high 80s to low 90s that fits the real functional definition of, I think the classic randomized trials from, and don't quote me on what country in Europe, but it was like you had to be mentally sound, live alone, be independent of your ADLs, and like get outside and walk a block a day or something, right? And so if they're doing those, I've done totals on people who are pretty old. And so I haven't used age as much as a cutoff. But you bring up an interesting point, because usually you're sitting there in morning rounds or something, and especially those at academic institution, the first thing that somebody says is like, this patient is too sick for X, right? In this case, X being a total hip. And I think that the thing that weighs on me is like, we've done such a good job, our colleagues medically, of taking these sick patients who are really sick, but happen to be pretty darn functional too. Their list of comorbidities is very long, but they're living alone, taking care of themselves, going outside and shopping, etc. So that's why the health trial in particular has really challenged me, like what to do with that now, because at 2 and 5 years, it looks like maybe there isn't a difference for hemis and totals. So I'll stop rambling, but that's kind of my long answer to your very simple question.
Go ahead.
No, go ahead.
I go with Dr. Natoli. I mean, I do ask patients what their functional status is. Another thing that I do ask is I look at cardiology or their internal medicine notes. Do they have medical clearance with METs greater than 4? Because we do know that any reason that patient inability to perform METs greater than 4 have about 20 to 30% of complication rate postoperatively for non-cardiac surgeries. So these patients, despite of their functional, if their body, especially their heart is not backing their activity level, chances of them getting benefit from total is lower, and that tends to do a hemi. But I do heavily look at their functional status. Do they go for grocery shopping by themselves? So do they take care of their house, and etc.? So those are the things that I look at.
I mean, I think it's absolutely critical to talk to the patient and determine exactly, what their function is, and, are they high functioning? Are they high performing? Because at the end of the day, like even in the health trial, like we looked at the, the fittest patients in the health trial, like the patients under the age of 70, ASA 1 or 2, and the patients did not use a walking aid and lived independently. And even in that patient population, there was no difference between a total hip and hemiarthroplasty. So, even an independent patient not using a walking aid is still not high performing. So I think you've really got to sit down and actually, figure out like what is high function. And it's only with that determination that I think a total hip is really merited. And it really is in that patient under the age of 70. If you look at registry data out to 15 years and longer, there's no difference between a bipolar and a total hip. The group that doesn't do well at longer follow-up is unipolar, whether that's modular or non-modular. But a bipolar at 15 plus years follow-up does just as well as a total hip in a patient that is over the age of 70.
Speaking of, how we evaluate our patients and their activity level, one question just came up in the chat, and how we approach morbid obesity for the panelists. Does that impact whether or not it's pushing you towards a hemi or a total in this patient population?
I think it has to do with activity level and whether or not they're high functioning and high performing. So I guess I'd have to try and figure out if a morbidly obese patient is going to be very active and high functioning. And, if they're not, then I would typically tend to do more of a hemi. I'd have to sort of sit down and figure out how active they actually are if they have morbid obesity.
Many of you may be familiar with the obesity paradox, whereby we would assume that the fatter you are, the higher your mortality rate. Is actually the opposite. So the highest mortality rate is in underweight, and then a little bit lower, normal weight, a little bit lower overweight, and then the lowest is in the obese group. Surprising, but if you look it up, it's true. So these patients, they have higher rates of complications, and they're more annoying for us to operate on, but they actually survive. So I don't know how that relates to your question, but these folks don't often pass away like you might expect they would.
For panelists, do you see a stress shielding, whether it's cemented or cementless, in your practice?
So yeah, this is something I tried to answer in the Q&A. I think it's really rare these days. Like I was saying in the chat, I was trying to explain. So proximal stress shielding is, I think, what the person's asking. That occurs when your fixation on your stem is more distal, and in older stems, cementless stems, that were much, much longer, sometimes you would pot distally and you would get more of that distal fixation rather than a proximal metaphyseal fixation. So your compressive stress is going to bypass all that proximal greater troch bone and proximal metaphyseal bone and get transmitted distally to the diaphysis. I don't think we see this as much anymore because modern implants are so much shorter, and the porosity on those stems is focused on the metaphyseal fixation. So we're not seeing as much potting distally with those stems, and we're just seeing more of that proximal good metaphyseal fixation and no stress shielding. And then for cemented stems, that's a really good question. If you have a good and equal cement mantle around the entire stem, you should have equal distribution throughout the femur from proximal to distal. If you don't have a good cement mantle and it's kind of wonky, then you'll have an unequal distribution of your compressive forces. And that's kind of the best way I could answer that. So you want a good cement mantle around your stem that's equal circumferentially around that stem from proximal to distal. You don't want the stem in varus or valgus. You want it central down the canal.
We've answered a bunch of questions about arthroplasty. There was a great question in the Q&A. I wanted to ask Dr. Okike about that Scandinavian randomized control trial for non-displaced femoral neck fractures, hemi versus fix. Significantly lower reoperation rate in the hemi crowd, and then equal functional outcomes with the exception of that timed up and go test, which favored the hemi group. I think you alluded to this in your interview with Dr. Harkin, but is that changing the conversation with you and patients with non-displaced femoral necks?
Yeah, I think certainly all comers, all non-displaced fractures, if you compare the outcomes fixation versus replace does better. I think the question is, yeah, as I stated, can we predict those who are going to fail? If we can eliminate them, can we get down to a rate that's similar to hemiarthroplasty? So me personally, I still haven't given up hope. So by weeding out anyone who I think has a chance of failing, over 80, any sort of tilt on the lateral, female, if I eliminate that entire group, can I get down to a group that isn't going to fail? And that's what I'm trying now, and it seems to be working, but surgeons always think what they're doing is working.
And as a follow-up, are you using in the individuals you're fixing, are you using cancella screws or fixed angle device?
I personally prefer a fixed angle device. The two fail differently. The screws, they just collapse into varus. There's nothing that stops that. I think in the fixed angle device, you'll sometimes have the head kind of collapse around the screw, and you'll have protrusion into the joint. They fail differently, but I personally prefer a sliding hip screw with an anti-rotational screw. And there was a question in the chat about FNS. I am not a fan. I think many who started using it have moved away from it. But I'd be interested to hear if there's anyone who's had good experiences with that device.
I mean, I don't use the FNS, and there was just a paper that was presented at the OTA talking about 11% incidence of subtrochanteric femur fracture, if I remember correctly. So I would definitely be worried about that. I must say I typically tend to use a sliding hip screw, which I think gives good outcomes. And in undisplaced fractures, there's no real difference with cannulated screws, but with displaced fractures, there does seem to be an advantage. So, I mean, I think if you use it universally, you can't go wrong. So if you've misjudged if there's any displacement, you've got the better implant with the sliding hip screw. And I think the other thing to bear in mind too with these fractures, just getting back to the conversation around internal fixation versus arthroplasty. I mean, talked a lot about failure and reoperation, but many of these patients with internal fixation shorten, and you'll see some series where more than half the patients have significant shortening, and A patient who's got the 1.5 centimeters of shortening after the fracture is finally healed is a patient who's not going to do well functionally. And that's one thing you can avoid when you're using an arthroplasty.
I'm going to call it turkey here. This has been a really excellent discussion, but we do have to stop at some point. We could probably go on all night. The one interesting observation I think I was just making is we should all probably become good at cemented hemis, because if we look at one spectrum, it's almost questioned whether for any femoral neck fracture we should be doing arthroplasty. And if we look at the other spectrum, when we're talking about hemis versus totals, it seems like hemis are, perfectly okay. So, that seems to be what will be the largest useful operation for the vast majority of people. All the caveats that we've discussed aside, there might be some outliers where we can drive the rates one way or another, or there's super functioning, people who benefit from totals, but doing a good cemented hemi and maybe through a posterior approach might be the best thing for us. There are a lot of good questions that we tried to get to, we maybe didn't get to, but the other thing that's going to happen is this is going to be available on recording, so you can listen to us as many times as you want and get all those excellent tidbits. We do have some upcoming journal clubs. So next month, patellar fractures, then subtroch, then MEPO, and then elbow fractures. So if you enjoyed this one, tune into those. I'm sure they'll be as good, if not better. And then for these next two slides, I'm going to turn it over to my colleagues at the AO, but this is really how we can continue the conversation over the next days to, ask some of those more deeper questions or get us to respond to some of the questions that we didn't get a chance to answer tonight. So thank you to all my panelists and to the moderators for doing the videos, for spending the time with us this evening. I really appreciate it. And then, of course, a special shout out to all of our participants who registered and got on to listen to us tonight. We really appreciate it.
Dr. Natoli. So essentially, My AO is a platform that was created by the AO International Foundation. It's essentially designed to bring surgeons together. The AO Trauma Journal Club has a group where participants can join in the discussion afterwards. So we will be posting the YouTube link to the My AO Trauma Journal Club page, and the discussion will start from there. It's essentially like a Facebook for surgeons, and it's a way for the conversation to continue to attract future participants. A way to interact and answer those questions that may not have been answered within the webinar's time restraints. And same things goes with this. It's all within the app, the My AO app, where you can go in and you can download digital or clinical cases, and there can be further discussion based upon the findings and what you have happened within this webinar.
All right, thank you, everybody, and have a great night, or in Dr. Okike's case, have a great afternoon.